You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor. We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
Dr. Samantha Siegel is an onco-PCP and survivorship physician at Kaiser Permanente. She has a passion for work in integrative oncology, AYA survivorship, and long-term toxicities. Dr. Siegel is the co-founder of PCP-ONC CARES program, a longitudinal cancer survivorship care model beginning at diagnosis, and she serves as the current Director of Cancer Survivorship for Kaiser Permanente, San Francisco. She is the host of AIM at Melanoma's supportive care podcast, Beyond the Clinic. Welcome.
Thank you so much for having me. It's really great to speak with you.
And can you share what brought you into the field of onco-PCP?
Yeah. Well, I guess I would say I just got here through really hard lived experience. It's interesting telling my story at various points in time, like telling it as I was going through it, and now telling it more with certain parts in the rear view and focusing more professionally on things. Because now going back and listening to all the various talks and podcasts and stuff, you can hear how I'm in different stages of healing, and the healing is ongoing. But yeah, I'm a survivor of relapse refractory Hodgkin lymphoma. And I am also married to a cancer survivor. My husband, who's also named Sam, is a testicular cancer survivor, an amazing person. And so, yeah, I was diagnosed with lymphoma back in 2021 and started off with a cough and fatigue. And I had a million reasons for why those things were happening and I wasn't feeling well. But then when I developed a painless rock hard lump above my collarbone that was rapidly growing, it was like, I think this is cancer. That was the undeniable symptom. I think cough and fatigue, it was like, oh, it's COVID. There were wildfires. Every doctor parent that I know is tired, who has 3 kids. Just a lot
of that telltale sign.
Yeah. Yeah. Just a lot of justifications for why I could not be feeling 100%. And then it was like the undeniable, painless, rock hard, rapidly growing, like there is a glacier forming above my collarbone.
Oh, geez.
Yeah. So in fact, it went from like, oh, this is probably nothing, to as soon as that was happening, it was like, oh, crud, I think I have cancer. So yeah, I underwent a lot of treatment over the course of 2.5 years, and had many, many complications. To name a few, I had hemorrhagic cystitis, which is bleeding in the bladder, pneumonitis, which is lung inflammation, chemo-related cognitive impairment, which is like the worst form of chemo brain with a lot of executive functioning difficulties, memory issues, just like planning and memory. So that was a lot. That was a lot to recover from. I had some kind of, I would say, like depression, going on and off of steroids and like other medications that really messed with neurotransmitters, and neuropathy, like just so many different symptoms. And yet when I reached the end of my treatment, it was like, yay, you're good. NED, like no evidence of disease. And it just, nobody actually said this to me, but it felt like the medical system was messaging to me like, you're good now, like just go on living. And I felt like, shoo, there was no process for, hey, you've just been through hell. this is going to take some time to recover from. Here's the process for how you recover from really intensive treatment like that. Here's how you heal. There really was very little about that. And I think maybe part of that was just as a system in general. I think we're still working on that. But part of it, I think there were some assumptions like, well, you're a doctor, like you got this, you could figure it out. And I didn't, it took a long time, a lot of different books, talking to other survivors. And then finally learning about the field of cancer survivorship, for me to understand, well, there is a system, there is this like developing medical field about how to help people heal, how to monitor for long-term and late effects. So, now I go back and I tell this in like a 5-minute Cliffs Notes version story, but it was 2.5 years of treatment and it was pretty brutal. And there were a lot of triumphs and there were a lot of like crying to the sky moments of surrender. But ultimately, it feels really good that I'm able to um, turn all that lived experience, those lived care gaps, into a medical model that hopefully will help patients.
Where were you in your medical or academic career when you were diagnosed?
Yeah, I was already working as an attending. So, for people who are unfamiliar with the MD process, I had done internal medicine residency. And then initially, I started off as a hospital based physician, a hospitalist, and then transitioned into primary care. And I had been working in primary care for a few years as just a general practitioner, a GP, before I developed my cancer. And then ultimately, after all the complications and whatnot, I just decided that if I go back to medicine at all, um, this is what I want to focus on. I felt that was a core belief that I held, you know, all the way through, was that I had just learned too much and I couldn't unsee what I had seen in terms of survivorship and what I had to share with people, so that if I got to medicine at all as a practitioner, that this is where I would focus my passions and my interests. And yet it was important to hold that core belief, because executing on that, and like nobody handed me like, hey, here's a program, go for it, it was really quite a struggle to be able to get to where I am now. And still it's a work in progress in terms of carving out how to now scale this like pilot program that we have.
Can you tell us about the Onco PCP program?
Yeah. So, PCP-ONC CARES program is our small kind of San Francisco limited pilot program that is a primary care model for patients anywhere along the cancer continuum. So, patients could be newly diagnosed, in the midst of really heavy treatment, or into post treatment survivorship. Um, and the reason that I felt, and it's not diagnosis specific, and it's not contingent upon being like done with treatment. So I felt really strongly about that being a core principle in our survivorship program, because one of the things that I noticed as a patient and then learning about this field professionally was that survivorship programs tend to be really siloed by medical specialty. There's like blood cancer survivorship and breast survivorship and gyn-onc survivorship, like depending on cancer type. And so a lot of the programs are siloed in those departments, and not every diagnosis gets equal attention. So there tends to be more resources for breast cancer as compared to like blood cancer survivorship. And yet the amount of attention does not directly correlate with the amount of suffering and the toxicities that people go through. I'm not saying one is necessarily more than the other. Even within those diagnoses, there's people who have like lighter, less intensive treatments, or more heavy treatment. But just saying that some diagnoses just systemically have more support than others. And so I felt that it was really important to just have a general approach for how do you take care of somebody, how do you think about their health and how to navigate them through the healthcare system, and address the different symptoms that might be going on with them across diagnoses. And then I also felt that it was really important not to just focus on people after they've finished treatment. And that's for a couple of reasons. One is that there's this developing term called metavivorship or metavivors. And metavivors are people who are diagnosed with late stage cancer, but are living active, full lives now. Stage 4 cancer in many instances is not a death sentence, as it used to be. And so people need support, not just like emotionally, but medically. They need not just their oncologist who understands how to take care of them and what medications and treatments are compatible with their ongoing cancer treatment or what they might be at risk for because of their ongoing cancer treatment, but they need like a whole team. They need more than one person in the medical system to advocate for them and to understand medically what's going on with them. So that's one thing. And then also just that there's so many really valuable concepts and tools in the field of cancer survivorship. And if we are only talking to people once they're, quote, in the clear or all good, we've missed the boat. Like, I didn't hear about the term survivorship until I was already deep in the pit of despair. And I just thought, once I learned like everything that survivorship means, I thought, gosh, this would have been really helpful to know, even if it was just anticipatory guidance. And what I mean by that is that everybody felt so happy for me that I was going into remission. I felt so much grief about what I had just been through, about so many things that had been lost. I felt totally like clueless about how to live life going forward. What did that mean? How do I like construct this new reality? And then once I started Googling and learning about survivorship, I learned that that's a really common experience, that a lot of people feel that way once they are in post-treatment life. Like once they feel a little bit more safe physically, that's when things hit the fan emotionally. And so even just that simple thing, you'd be amazed. Like when I tell somebody who's about to finish treatment, like, hey, it's really exciting and you know that you've reached this point in treatment. I just want to let you know that it can be really common to have this downturn in your emotional well-being after you finish active treatment. And that's completely normal. Like just normalizing that. And people are like, oh, I'm so glad you said that. Like it's really hard. And I felt guilty for not feeling just 100% joy about finishing treatment. So even just being able to give a little bit of anticipatory guidance to people about the different things that they might go through, and sharing that information earlier on, like from the time of diagnosis, and mentioning it over and over again with repetition, like all the way through, it's really transformational. So yeah, the core beliefs were survivorship starts at the time of diagnosis and extends through the balance of life. That's how NCI defines cancer survivorship. So it starts at diagnosis, shouldn't be contingent upon, like the amount of help that you get shouldn't be contingent on your diagnosis. And let's help deliver some of these really important concepts to people like as soon as possible. And even if they forget everything you say right at the beginning, like you just keep revisiting it over and over again. So those were some of so that's what our care program is in PCP-ONC CARES program. Like wherever you get hooked up, we have an intake appointment. So this is a little bit of a departure from traditional panels like within my healthcare system. Like within our healthcare system, if somebody's panel is open, my patient can just like elect to switch to you. But that's not how we have created it. We have created it to where it's closed and then a patient needs a formal intake appointment in order to become impaneled on the service. And then we also do consultations for other PCPs who the patient wants to stay on their panel, but the other PCP is like, hey, can you just take a look at this person and make sure that I'm doing everything that I need to be doing for them? And because we have a little bit more time for these appointments, we are able to do that. And so we have this really amazing intake appointment that you can think of as a combination between primary care and palliative care. Like we talk about goals of care. Sometimes we talk about death, even if the person is nowhere near end of life, but just because it's very natural to think about death when you've gone through cancer, even if you're through treatment. We talk about like who's in your support system, how's your financial well-being. Did you start this off like, you know, being okay financially, and now 2 years into it, there's like heck of financial toxicity because of the treatments. So we have this like moment in time where we just, you know, we clean up the med list, we go through the med history, we make sure that you've had recent like basic labs that a lot of survivors miss somehow, like lipids, A1C, which is glucose. So it's just this point where we stop and we just make sure that all these quality care gaps are being addressed. And then we really make an effort to connect people with other supportive programming that we have in our system. So psycho-oncology and nutrition and sometimes palliative care, whatever might be appropriate for their situation, given their diagnosis, what they've experienced, and what might be going on for them.
How does the onc PCP kind of differ from your role in cancer survivorship?
Yeah. So I think that there's a lot of similarity, and we're certainly not trying to replace any of the amazing survivorship clinicians that are already existing in our healthcare system or other healthcare systems. I'm still learning a lot about survivorship from those practitioners. And in fact, many survivorship programs within our healthcare system and around the country are run by nurse practitioners and physician's assistants. And they've been doing this for a really long time and they know a lot more than I do. So the patients will sometimes still see them, but the cadence of how often they're able to follow up with those individuals is often less frequent than a patient might be able to have access to me. So they might talk to that person like once a year or twice a year. And so, and the survivorship programs in general tend to start with people who are post-treatment. So that's really the big difference, is that ours is onco-primary care is more of like a generalized non-cancer specific approach. And it can start anywhere along the cancer continuum. And when you're somebody's onco PCP, like you really are playing an active role in care coordination with oncology, with radiation oncology, with surgery. Like you're an active member of the team. Whereas in survivorship, it tends to be more focused on that particular diagnosis, and it's more of like a time-based thing that you get connected to once you've reached post-treatment. So those are really the distinguishing factors. But I love when my patients also have visits with the survivorship programs that are housed in the various departments, because I'm learning a lot about the things that they do and they look at. And a lot of this is just apprenticeship. There's no onco primary care like board certification at this point, or cancer survivorship board certification. So at this point, it's really all self-taught and apprenticeship and mentorship with other people who are in this field, who have developed this interest, who are reading and educating themselves. So that's kind of where things are at right now.
I had another follow-up question there. I'm curious what like your referral process looks like as far as who's captured. Is it more so those that are in active treatment that want to then have like an established then primary care physician seeing them going forward, or is it someone, or is it like a mix where it's those that are already through the process and are then completed with their active treatment?
I would say it's all over the map. And I find that really interesting and important to say, because um people,
Yeah.
the amount of suffering that somebody is going through, or how great, how many symptoms they have, or things that they might need within the healthcare system, it it does not always relate to what stage cancer they have, or whether they're on active treatment, or they might even be years out. So I have patients who are living with active stage 4 disease, and they would consider themselves very healthy people with a great sense of well-being. And I have other patients who had early stage cancer and they're years out from the end of active treatment and they're still suffering greatly. So I think that's really interesting thing to notice, that depending on what is going on with each individual person, it can really be just all over the map. And I love that about this field, because what I do for somebody and how I relay the conversation that we've had into the medical record and then communicate it to other members of the healthcare team can just vary so much. I mean, I had a consult with somebody just recently, and it really was understanding that years into this and after multiple cancer diagnoses, like the financial toxicities were mounting extremely. And also, this individual was really had a strong desire to communicate to members of the healthcare team that they believe in Chinese folk medicine, and felt that that's really important, and so that was really the extent of that call, was just to like relay those things. Um and yet that conversation, because of like language differences, whatever, can take a while to really fully understand and see somebody, and then translate that and write that into the medical record. And yet for somebody else, it might be like, newly diagnosed, about to head into treatment. Maybe they've had some like liver inflammation based on their labs, and you know, other lab abnormalities that raise concern for like they're about to head into treatment. We really need to optimize all the organ systems, to make sure that all systems are go for the treatment that you're about to put them on. So it can vary between like more of a psychosocial focus, and really understanding like their family systems and their emotional healing and connecting them to treatment and systems within Kaiser right now. Or it can be just more traditional allopathy, like we're looking at your labs. Maybe you're somebody who's like on treatment and you need a lot of steroids because you're being treated for complications from your cancer, and that's what the steroids are for. And now you have steroid induced diabetes, and so you're on and off of steroids, which means that your insulin requirements are going up and down. And so how this differs from a traditional primary care model is, a lot of times people, you have somebody on a treatment regimen, and then you get them to their goal glucose or hemoglobin A1C, and then you only need to talk to them once every 3 months because everything's pretty stable. But in this patient population, people might go on and off of treatments that are making their sugars go up and down and up and down. And for safety, you might need to talk to some of those people like once a week or every other week, to make sure that the insulin that they were on last week when they were on a lot of steroids is now like mirroring the steroid taper, and you're reducing that so that they're not tanking out with their sugar. So that's a really interesting thing, that because of the various treatments and complications that people have, the cadence of care and follow-up is much more intensive. But this is also why I really need help. Like, I really want to grow this program beyond. There's one other doctor who's doing this with me, and then we have an oncologist that is our partner in crime in our healthcare system, and has helped us, like, put roots down for this program. But we're still really small. It's she and I, and we're only limited to San Francisco. But my dream is that this ultimately just becomes the norm for cancer care, not even just in Kaiser. That when somebody's newly diagnosed, they get an onco PCP, they get somebody who understands like the cancer experience and is there to help shepherd them through all the way along.
I love that. I had like this image of like going on the roller coaster with you, right? All the ups and downs,
Mm-hmm.
and
Mm-hmm.
along for the ride.
Well, because even there were some like language things that I noticed all throughout this. Like people would say, "Oh, well, you'll get to the point where things will be stable enough, and then we'll transition you back to primary care." Like oncology will say this sometimes, "We'll transition you back," and I thought that implies that they haven't even been there. Like transition back implies that you were discharged from primary care to oncology, and that you then need to be transitioned back. Why can't it be that everybody was there all along? So then I was thinking like PCP-ONC CARES program, where a transition back to primary care isn't necessary because we never left in the first place. And it's not, that's because we've been there all along. Not to say that PCPs leave, but I think that it's really complicated because traditional primary care doctors are over impaneled. They don't have time. Their visits are super short.
Oh
It's
yeah.
just like not uh it's not rooted in reality, the amount of time that like there's this whole like you have enough time for like one or two things when you see me in primary care. That doesn't work in cancer survivorship. There are like 5 or 6 needs almost every single time because of the intensity. So um yeah, that's one aspect. They're over in panel, the visits are too short. It's just not a complex chronic conditions focused model. Like a typical primary care doctor's panel will be a combination of people who are completely healthy and then people who have chronic health conditions.
Those zebras, right?
We Yeah, in our care model, every single person has chronic health conditions, and so we need a different approach. It's slower medicine, but the intention being that if you get people the right care that they need at the right time, then hopefully you're preventing problems down the road. But this is why we really need to work with researchers within our healthcare system so that people can study the care model to be able to prove the business case of this, because I think that's really going to be the thing that helps us to scale beyond just a couple of us, is that once we can show, hey, we do save money, we improve outcomes, things like that, then that will really be when big systems want to invest and grow a program like this. But it's early days, so I need partners to help prove those points.
Wow, I wish this program was around when I was being treated, because it sounds like a dream come true for treatment. And it's very clear that your motivations to like help build this program is from this unique perspective that you have now from being a
Yeah.
survivor. Uh, how would we get that research to start happening, I guess, for your program? Is it just the recognition, or is there a process that programs like these go through to get the researchers on board?
Well, I think that there are definitely cancer survivorship researchers. There's and advocacy organizations. So I've become, involved with those for quite some time. And I think that there's definitely people who are interested, but Kaiser itself as a healthcare system, I think it needs to come from within our organization. So I'm in the process of reaching out to people within our division of research. And, I think it would need to get a grant to be able to have somebody who would be able to be assigned to study the healthcare model. So um, I think that's just the time point that we're at right now, is that the first year was really about proof of concept. I mean, we just kind of passed our 1 year time mark, a little bit, a year and a few months. So it was really about proof of concept. Like, this is a thing. And I think that we've adequately demonstrated that, like, this is a thing. People doing this care have a different approach and maybe some specialized knowledge. And part of it is just like pattern recognition, like seeing the same types of patients over and over again and working through the various challenges that you work through, and then building these pathways for knowing what to do when you encounter that kind of situation. So I think that was a lot of the work of last year. And um, now it's time to sort of buckle down and figure out who do I need to talk to within our healthcare system so that I can get some partner on the administration side, the business side, to be able to say, like, what matters to you, like what can you help me look at within this program, so that whoever makes the decisions about money and resources can decide that this is worthwhile enough to get us more bodies to be doing this medicine and be doing it the way that we're doing it now.
Well, with a
So
proof of concept, I'm curious, is there like a quality improvement project then and highlighted with the PCP-ONC program?
yeah, no, I think that we've done a lot of different quality improvement type projects, and in fact, um yeah, I mean, it's like dizzying the amount of things that our program has done. And we have residents rotating through now, like once a week or once every other week. We have a resident that's on their oncology rotation, and now they come and they spend an afternoon with me, and they see the patients that I see. And it's amazing. And we also have a psycho-oncology pilot program that started almost about the exact same time. We recruited this incredible clinician named Dr. Anahat Singh, And she simultaneously, like in parallel, built a solely dedicated, cancer focused psychology program. And so there's a lot of referrals back and forth. And so that's an interesting thing when you mentioned to like, well, who gets to you? Like there's so much cancer, especially if it's not focused on one diagnosis, who gets to you? So a lot of the first year, many referrals came from her, actually, with her talking to somebody and a patient just explaining that they felt like, unseen, or felt like a lot of the things that they were dealing with, just they weren't getting the kind of care that they needed. So many referrals came from her. Sometimes referrals came from people in the hospital, or sometimes they came from oncology. So it was really interesting. But yeah, we had a resident who's now a fellow who did a research project on, peer support program. So there's just been so much that we've done over the last year. It's amazing.
What treatments are you excited in cancer care?
Yeah, well, I just finished my integrative medicine fellowship through the Academy of Integrative Health and Medicine, which was an incredible 2-year program, and still have to take my boards next year. But I'm also really excited about just having an integrative mindset for cancer survivorship. I sort of view them as one and the same. And I don't think that a person needs to have necessarily done an integrative fellowship in order to have an integrative mindset. And what I mean by that is that a lot of the tools that are helpful in integrative medicine are just naturally part of survivorship. So, movement as medicine, that's an example. Like, just getting cardiovascular exercise to help heal your brain after intensive cancer treatment, to use that as a tool for improving mood. I remember one of my light bulb moments in my own cancer recovery is I was just really, really down after tapering off of like all the meds that I came home from on transplant. Like I was on opioids and benzos and like nausea meds, just like a lot of meds. And I wanted to get off as soon as possible. So my genius idea was get off all those meds while I'm on high dose steroids. And that was just a recipe for like mental health badness. And so I had just a rough couple of weeks as my neurotransmitters were resetting. And in that time, I was just so desperate to feel better. And I watched this documentary called Stutz, which I forget the name of the actor, but this young actor, and he's talking to a psychiatrist. That's what the movie's about. And he'd been in Hollywood for years and years. And he was talking about how people had always been on him about diet and exercise for like vanity's sake, so that he could be healthy and that he could like look good in the movies. And then when he talked to the psychiatrist,
Jonah Hill.
oh yeah, Jonah Hill, and his light bulb moment was about like, well, movement as medicine, like exercising to be like to just get yourself out of the doldrums when you feel horrible, that and and that really impacted me. Like that's when I was like, okay, I've really got to move my body and sweat, not for future, 10-year down the road, hypothetical cardiovascular risk reduction me, but because I feel so bad right now. Like I'm having trouble just living my everyday life and I need to feel better. And so I need to just like sweat 20 minutes a day and like I'm working to breathe a little bit, and I'm in that zone, like zone 2 or whatever of exercise, and to do that, like my life depends on it, and I did. I mean, I was super diligent about that. And then cleaning up my diet, taking out processed foods, and instead of like cutting things out, just really thinking about food as medicine. And every time I open my fridge, like what medicine can I put in my body next, anti-inflammatory foods and just really highly nutritious food. And dance and like social connection, learning how to be around people again after being really isolated for a couple years in treatment, and all of that is medicine. And so my integrated medicine fellowship really reinforced that, along with the use of like very select um you know dietary herbs and supplements and for instance, like just addressing root causes. If somebody has like severe vitamin D deficiency or like really low iron and their legs hurt, instead of just saying, well, you've got chemoneuropathy, like look for underlying root causes. You correct the iron, you correct the vitamin D, and even though they might still have chemoneuropathy, like their legs hurt a lot less when you correct what's correctable. And then maybe add in a little bit of acupuncture and just kind of have that whole comprehensive approach. And so that's, I'm excited about that. I'm excited about utilizing all the different things that we can to help somebody to feel better, and to just live life more fully and help people kind of realize their vision of what is vitality in cancer. And my ideas about this were really inspired by friends that I met in peer support groups and in the cancer community. One of my best friends, who's no longer with us, she passed away at age 26 from blood cancer, and I knew her for the last year of her life. And she was the most alive person that I ever met. And yet she was only in remission from her blood cancer, I think 5 days out of that year that I knew her. Like she just kept relapsing and going on and off of treatment, in and out of the hospital. But she was having intimacy with her boyfriend. She was doing art, whether it was from her hospital room. She was like reaching out to celebrities that she wanted to meet and like having video calls with them. Like she just wanted to be in this life so much. And I think that sometimes the medical system, not because of any one person intentionally, but the medical system can treat somebody in those circumstances sometimes like that person's terminally ill, they've got one foot out the door, And she just really rejected that. Like, I want to be here as alive as possible. And even though it may not look like a life that you'd want to live, like being in and out of the hospital and in the ICU and this and that, for me, this is still really a life worth living. And like, whatever can you do for me to help me to like feel better and seize the day, whether I'm in the hospital or at home or things like that. And so, yeah, I just think that there's a lot of opportunities, and it might even be just a conversation that you have with somebody. Like that was one of the biggest realizations throughout this. Sometimes I'm the medicine. Sometimes I have nothing else to offer somebody in terms of a prescription for a pill or a procedure. Like sometimes just talking to somebody and understanding their circumstances, what they've been through, what matters to them, what they're afraid of, like that's the medicine. And my integrative medicine fellowship helped me to realize that before I got sick, I used to feel that if I didn't have any prescription to write or test I could do to help somebody feel better, that I felt like I had failed or like I was coming up short. And now I understand that sometimes I'm the medicine and sometimes our relationship is the medicine. But that requires me taking care of myself. And that's also a departure from like, there's a lot of people, burnout is rampant in medicine, just in a lot of different fields. And so I have to like prioritize myself and sleep and exercise and take care of myself so that I can continue being like an instrument for healing.
I love how you worded that, acknowledging that you're part of that medicinal treatment and that your own process with having the realization that like it isn't necessarily a failure if there isn't anything else that you can do as a prescription, but then to then listen to them and then have them feel seen and heard and have that whole body approach like you were just really explaining in this integrative mindset is more powerful.
Yeah.
And so I just really wanted to reflect on that.
A lot of patients have told me that they feel this tremendous abandonment toward end of life, especially where, and I think most cancer doctors or doctors in general don't mean for it to happen this way. This is just like how our healthcare system is constructed, but it can feel like an assembly line where once there's nothing left to do, there's no more medicine to prescribe or procedure to do, then you go to a different team that takes care of that part. And that feels really bad for patients sometimes. even if it's well-intentioned and like that's the different team's area of expertise, to then like be pulling away from a team that's known you the whole time until there was nothing else left to do. And then you go to somebody else for the death and dying part. That can feel really bad. So that's sort of another way that we try to undo some of that, is to maintain a little bit of this thread of like being there all along.
I think that's really powerful. I actually had something really similar happen to me during my treatment where I was passed on to a different team for a part of my treatment. And then there's no communication. At least at that time, there was zero communication about what's happening. So after I finished treatment with them, they were like, "We want you to go back to your old doctor." But they didn't really communicate anything. So I just thought the new team I was a part of abandoned me. And it wasn't until 20 years later when I went to visit the site that they're like, "Oh no, that's just the protocol. Like, your treatment changed, so we didn't need to work with you anymore." And it was like, but there was no communication at all. There was no like message from my doctor like, "Hey, you're doing great, and now I want to put you in these other hands that are going to take care of you better." It was just like, "Oh, okay, I guess I'm going to this person now." And I guess that doctor didn't like me. And that's what we thought for like 20 years, is that they just disliked me or something.
Oh my God, that's so painful.
Yeah.
Right? And I love that you brought this up, because I think part of our intake is we ask patients like, do you want to share anything about your cancer narrative, or do you have any underlying beliefs about your cancer, or anything that you want to share about your cancer process? And we have some patients who might be 10, 20 years out. And sometimes people will share things like that, like this deeply held belief about something that happened and kind of undoing it now. And no matter where somebody is in the cancer continuum, there's value in healing that, because then they're like, oh, it was just a change in protocol that was poorly communicated to me. Like, it wasn't me. That feels good to let that go so that I can like live more fully in my life. Or sort of reestablishing trust in the health system. I think that sometimes healing those hurts, even if they're remote, can help people to be like, okay, like I can trust medicine again. And I'm not saying that we're perfect, and I still mess up all the time. Like, even showing up with all my knowledge and my best heart, like I'm still just, you brush off the day before and you just keep showing up, just trying to do your best. But I'm glad that you were able ultimately to realize that was, it was a change in protocol and that it wasn't you. And
Yeah, I
thankful.
also love what you shared about sometimes just your conversations is the best medicine you can share with a client, not necessarily a treatment, because, my experience, I had a very low chance of surviving. And then my mom, who's in remission, had a very rocky treatment process. And the thing that got us through is just continue to remind ourselves you're not a statistic. But like, doctors look at the statistics. They're like, you have this percentage of survival and this percentage of not being successful. And like the data in your mind is like, like, why do you got to tell me this? Like, what if I'm a part of
Yeah.
the percentage that's going to be successful? You're like looking at data after the fact,
Yes. That is such a great point, because that's another thing that we try to do. I mean, I think part of what we do is sometimes like cancer coaching, or we're reflecting back to people, like they've had a conversation with their oncologist and now they're in the space of processing everything that was said before they go back again. And so sometimes they'll communicate what they thought they heard, and then questions that they might have, and I help them to like formulate whatever their thoughts or questions are for the next time. And a lot of that will be around like statistics. So I don't like go on and quote what the oncologists have said about statistics, but what I will do is I will help somebody try and understand why they're asking the questions that they're asking. So I'll say to somebody like, well, is it really important for you to know that statistic? Like, why do you want to know that number? Do you feel like that's going to help you live differently? So if it's going to help you take a different action, like you're going to like quit that job that you hate, or you're going to like put your will together finally and you've never done that before, and knowing that number is really going to help you do that different thing in your life, then sure, maybe it's important. But if you're already living the life that you want to, and that's not going to help you take a different action. It's only going to keep you deeply rooted in that place of fear, then maybe it's not going to be helpful. And so the conversations are just a lot more nuanced, I think. We always learn about like autonomy and, beneficence, and just making sure that patients have all the information. But I think it's a lot more nuanced than that. And how is the information communicated? Asking a patient, like, do you want to know like the median or mean survival or average statistics? And so there's that aspect of it. Like, why do you want to know those numbers? And then also just, I think prognostic information is really going to change in the next couple decades. A lot of the previous like prognostic information that we have on things was based on like old treatments. And now we have new treatments, and we have different ways of like monitoring people. Like there's this thing called ctDNA, which is going to be the thing of the future, circulating tumor DNA that looks for disease cells that you can't even see on a scan yet, but we're just not quite sure how to use it or what it means or how to make treatment decisions based on that. So it's just going to change.
But that's what the precogs are for, right?
Precognition, yeah. Like, yeah. No, it is. It's really cutting edge stuff, but there's companies out there marketing that stuff. So I just think prognostic conversations are really going to change, and that translating like prognostic information to individual practice is really like a skill.
That sounds like a really cool then cutting edge kind of approach to and look at these things.
The communication aspect of what we do is really extremely important.
Yeah, I think it's very nuanced, like you said. Sometimes it's helpful, like
Yeah.
if you're going to have a surgery or something like that, you're weighing like the pros and cons. But during cancer treatment, hope is kind of what pulls us through. Like, am I giving up, or do I have hope? And I'm going to do the exercise, eat the anti-inflammatory foods, like you said, and just keep putting my best foot forward.
Kelly Turner, she wrote this book called Radical Remission, and I feel like it's a really powerful book for many reasons. But she has this line in there that says, "Believe the diagnosis, but not the prognosis." So I think that's a really interesting point that she has, where it's very important for people to work with their allopathic doctors, their oncologists, their primary care doctors, and to keep themselves like rooted in the Western medicine. And yet it's also important to know like when to tune out and to like just stay really connected with your own experience and your own reality, and not take too much to heart what the healthcare team has said, like it's just like it's prophecy. And so I think that is a really um like it's hard to figure out that line of like, when do I listen enough to make sure I'm like doing what my doctors say, and but also like know when to ignore them and walk my own path.
I was going to say, or get a second opinion kind of thing.
Or get a second opinion. Yeah, exactly. I was really, really obsessed with the numbers my first time through. Like, I mean, I was looking up studies and I had my check boxes and like my lists or whatever. And then and I had a cancer the first time through with Hodgkin lymphoma. The numbers are really good, like 90% cure rate. And then I relapsed within a month. And the data on relapse refractory Hodgkin lymphoma is not nearly as good as the first time through. And so at some point, I just stopped looking at the numbers. And I'll never forget this one time. I was on the way home from a PET scan that I had. That was the one that was going to determine whether I was ready to go into bone marrow transplant. And I rolled the window down and I was like bumping hip hop music in the car. And I just felt like the wind blowing over my bald head hanging out the window. And the line that I kept thinking, and I wrote it down in my diary when I got home, was, I don't need a PET scan to tell me how alive I am. And that's really how I felt. Like, and ultimately it was good. And I went on to transplant and stuff. But I just, in that moment, I felt so just like fully alive. And I remember thinking that was really powerful, that to separate how alive I felt without knowing the results of that scan. Because I think that the whole aspect of scanxiety and um, that scan, that result is going to determine my future, and like, do I have permission to live or not based on what that result is? Like, there's a whole psychology to that that's really profound. And anybody who's had multiple scans, I think, can relate with that.
Yeah. One thing I wanted to maybe have us wrap up on is curious how your experiences through your own cancer have kind of informed how you are addressing cancer survivorship now, or if there's a particular uh, then direction that you want to continue going in.
Yeah, I think that some of definitely my experiences have informed, just really, I think, the whole personhood of what we're doing. And what I mean by that is that I really try to understand, um, who's around my patients. So like if they have kids, how are the kids doing? Knowing that that's not just like a social question, that like a side note that's fluff and that doesn't really matter for the medical situation. Knowing for me, one of my biggest triggers for FCR, or fear of cancer recurrence, was like the look on my kids' faces looking back at me, processing like how I was looking to them. And so it was only once they I got them help by connecting them with Camp Kesem, which is a free 5-day sleepaway camp for kids who've been impacted by a parent's cancer. And they would go to that, and they found community with other kids who were kind of dealing with similar things, um and getting more help in their lives to carry the like hope and resilience and sadness of all of this. I started doing better. And so now I ask that, knowing that it's not just like a social fluff question that will directly relate to how well my patient is doing, by acknowledging like the weight of everybody who's in their family system, and by helping to connect them with whatever resources I can, and not just thinking like, oh, that's just the social worker's job. Like, I consider that part of my job. If I happen to know that they have kids at home or that they're going through a hard time, like I will try and look something up about what organization they might connect to. So that's one thing. Also, just understanding through my experiences with like my friend Tati that I told you about, who opened my eyes to the need to talk about intimacy and sex in all stages of cancer. Like, people who have quote terminal illness are still having sex sometimes, and so just like, not there's never an impolite time to ask about it. Patients will tell you like, no, I'm really not interested in that right now. Or some people be like, yeah, and can you please give me advice about how to do this safely? Because it's really important for me to like live this part of my vitality as long as possible. That, and then also asking about the D word, death, and just trying to undo the whole mentality of like, we only talk about that when we feel like you're near that part of the conveyor belt. Like, just, talking to patients, like, it's okay to talk about death whenever. Like, we are all mortal beings. And sometimes I think when you acknowledge death or fear of death, um it can help somebody live more fully. And I try to always follow up death conversation with life conversation. And what I mean by that is that we'll talk about advanced directives, or have you ever talked about what you might want to do in the event that you can't communicate for yourself, things like that. And then sometimes it really shocks people, especially if they're like not even thinking about that because their cancer's doing fine or whatever. But then I'll try and follow that up with, and like, what makes you feel alive? What gets you out of bed every day? Like, what gives you meaning and purpose in your life? And that helps to sort of lessen the stress of that, and kind of messages to the patient like, this is all part of the human experience. So to just kind of elicit some of those deep like fears and hopes, and internal experiences, and then not just elicit it, but to then like document it and communicate it to other members of the healthcare team. So that's kind of, yeah, I think that that's part of that's part of the difference of like, this isn't just survivorship and this isn't just onco-primary care. Like, that's really where I'm trying to translate the lived experience of not just me, but like when I've talked to hundreds, maybe thousands of survivors at this point, and take everything that I've heard from them and then translate it into a care model. And that also means that this is dynamic. Like what we're doing now might not be what we're doing 6 months from now or a year from now. Like, it's going to be always changing, and people are constantly telling me like, I don't think you did this right, or like, I think you could do this better. And I really try, and like, even if it hurts a little bit sometimes, to like think about that and think about how to incorporate it going forward.
I love that. And I just wanted to offer my sincerest gratitude for what you've done in carving your own path. I really enjoyed hearing about your passion for really looking at that. I call it like that whole body approach, and really interested in all these different factors. You know, as a psychologist, I think I'm like, oh, this social determinants of health. Can you like all these different things that come into play with how you know, they're showing up, you know, their family life, their intimacy, like you said, their thoughts on death, and I think it's so gosh, stumbling over words. It's just refreshing to hear that perspective that you have for your patients, and what you want to have, you know, and for this program. So also wanted to then offer my sincerest gratitude for Dustin, you know, for being able to then being my wingman, ride or die, one of those.
Cancer podcast wingman.
There we are. Yeah,
I love it.
But wanted to thank you for your time as well, and just offer our appreciation for you being a guest for today.
Thank you both, and thank you for sharing your experiences also, and translating the paths that you've walked into these conversations. It's so, I don't know, we're so lucky that we're here, we're able to do this. And I think it helps like the pain of it a little bit, you know, to just be able to share this and to laugh and relate with, like, in a way that only other survivors can really appreciate fully, you know?
Yeah.
Yeah. So it's just great to meet you guys, and thanks for having me.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.